Hello, everybody, and welcome back to Recovery Machine. I'm your co-host, Nathan, and over here we have Corey. How you doing, Corey?
Hey, Nathan, I'm good, thanks. How are you?
I'm doing well. It's Saturday and it's sunny out here in Kelowna, which is nice. I'm probably like the rest of everybody else out there feeling the weight of the incessant chaos in the news and the strange state of affairs with what's going on in our country right now and around the world. And we've been talking about it a little bit in meetings throughout the week, how it's kind of added a layer of complexity to, everybody's day-to-day life. You got your normal worries, your normal concerns. And then on top of that, you got this thing in the background, if you know what I mean.
Yeah, absolutely. I think it's important I said that in a meeting this morning, to give ourselves credit for that, to give ourselves a little bit of permission to feel that that disease or that sense of stress or doom and gloom or however you want to put it, that it's very much a real thing, and it does take a toll on us. It does take a toll on our mental health and our sense of well-being.
Absolutely. And kind of the quandary I find myself in is what to do with that thought process, as far as, okay, I'm aware that that's going on. I would categorize that as something that is, for the most part, beyond my control. There's not a lot I can do about most of it. So, therefore, am I supposed to just ignore it and use no mental energy and focus on everything else? I suppose logically that would be what you'd want to do, right?
Yeah, or at least really, really put a cap on how much you take in. That's what I try to do. And I try to check in and see what's happening in the world or in our country every day. But I really put a limit on that. And I forgive myself if someone tells me something that's going on or an update of the current events, and I say, oh, I hadn't heard that yet. And I almost feel proud of that, because it means that I wasn't taking in that information constantly,
Yeah, that is kind of it's a badge of honor.
Yeah.
To me, it means you're paying enough attention to know that you've got to reduce or throttle that input.
Yeah. And I'm old enough to remember the days of not necessarily hearing it until you watch the 6 o'clock news. And, to go back to those days, I think all of us probably think at times that how sweet that would be.
Yeah, absolutely. Yeah. Even if it was all nonsense and who knows how much was true. And I mean, that's one thing that the internet has brought, is kind of an illumination of how much false and true there is out there. But today, I guess what we're going to do, we decided we're going to take more of a broad kind of scope of the federal government's kind of strategy, as far as, you look at the state of the country. We appear to be, especially BC, where we continue to trend in the wrong direction as far as the opioid crisis is concerned. What is being done? What has been planned? What has worked? What has failed on a countrywide scale? And then we'd like to go over how that pertains to the people on the front lines in healthcare.
Yeah.
How that trickles down and what kind of an impact, if any, it has at that level. So, maybe if you'd be so kind, Corey, could you start us off with what they consider to be the 4 pillars of our current strategy?
Yeah. So the 4 pillars, as they stand or don't stand now, are prevention, treatment, harm reduction, and enforcement. And we're going to break down each one of those and get into the impact of each one. We could spend hours and hours and hours and get into statistics and get into debate, depending on who you are and your political lean or your job or a number of factors. You could have a different opinion on each one of these, but we want to look at it in fairly general terms and look at from a healthcare worker's perspective too. Is it working? Is it not? And then kind of look outwards a little bit from there.
Yeah, I mean that's one of the things I think that we can do from our position, right? Is shine a light into areas that other people haven't seen, especially pertaining to our specific careers and professions. And then, I mean, even every time I look at this stuff, I see something else. It's there's a tremendous amount of information, and you're right. You spend a lifetime just going over the politics involved with these decisions, how the current kind of feel in the country, and how our surroundings, like being the neighbors with the United States, how that's affected us, and it's interesting stuff. But yeah, it'd take a long time. So we're going to try to stick to the four pillars as far as what we know about them, and we'll break it down for you guys. One thing I wanted to just kind of point out as far as the history of this program. I mean, if you go all the way back into like the 1920s and 30s, there was many different kind of ideas about how drugs should be approached. When we got to 1987, Canada put their first revision of what is actually the current model forward as the Canada Drug Strategy. It was the same thing. It had the four pillars: prevention, harm reduction, treatment, but most of the emphasis and by far most of the money was going towards enforcement. So that was the 1987 model. And then in 2007, they switched to a more, it was called the National Anti-Drug Strategy. And this one was an even further kind of ratcheting up of enforcement over compassion. So very much looking at this like a problem with a weakness in society from the top to bottom, and trying to eliminate substance abuse from everywhere. Just that kind of approach. So interesting to see that we were trending in a good direction. Then 2007 actually backpedaled more into an going against the evidence and the research and the science towards a more kind of conservative approach, I guess you'd say.
Yep.
And then now in 2016, we're back to the four pillar approach. It's been renamed the Canadian Drugs and Substances Strategy. And same type of thing, same four pillar approach. And we'll discuss kind of what kind of resources are being put in and what's being done differently, etc. Yeah. So I guess we'll look at prevention first in just a general sense, eh?
Yeah. Yeah. So the question that we had was, what is being done to prevent drug and substance use in the general population first? Which is to me, when I was thinking about these questions, I kind of thought we're starting from one of the hardest pillars to look at least the one that probably is probably the most gray and probably has the least evidence behind it. I would venture to guess, in that we're not looking at numbers of incarcerations, we're not looking at numbers of deaths, although those are certainly things that factor in and that you can make a part of the conversation. But it's gray, because to me the conversation about prevention is so much the conversation about mental health and the conversation about with our youth. It's a conversation of how it occurs in our schools, in the education system, and it's a harder one to quantify, I think.
Absolutely. Yeah, I was thinking about ways that you could address that. And one thing that they like to say, especially in this new model, it's if you go online and you look on the Canadian site, there's probably 3/4 of it is just word salad, basically appeasing different special interest groups with a bunch of nonsense words about education, and usually it's increasing access to care. These are the terms they use, but then when you follow those terms and try to find out what actually has been done, like where can you go what do you mean by education? Like, are you handing out pamphlets? What's the, you kind of come to this delta of dissipation, and there's not a lot there. And I think from a healthcare point of view, we've all seen doctors, the stringency with which they're allowed to prescribe opiates and benzos and medications like that has now been cranked way up past, I think, actually quite a ways past what it should be, to the point where a physician can no longer, if a patient comes in and they just write a prescription for one of those drugs, they need to follow up and actually explain on a separate document why they did that.
Yeah.
And of course, we've seen what that's done to people who are suffering with chronic pain situations, complex pain, and neuropathic pain, where they may have been controlled or had their situation under control medically, and then all of a sudden they're faced with a quick taper or being completely cut off because their doctor is facing pressure from the government. So, I mean, that is something that I've seen as far as they're trying to prevent the amount of narcotics getting out. And that comes down to, we see that in paperwork now too, and narcotic reconciliations. There's, they've cranked it up. Basically, do everything you were doing before, only do it 3 times as often.
Yeah.
Like, what kind of a difference is this going to make?
Yeah, I'm not sure that it will.
Me neither. I haven't. What I've seen is, I've seen a lot of law-abiding citizens who are having a lot of trouble accessing medications that were helping them. I'm sure that there are other people who didn't access medications based on false premises, but I don't know. It to me, I don't like I don't like what's going on with the chronic pain regulation right now. What I thought, and maybe you could tell me if I'm on the right track here, but I thought it might be useful. One of the things that you could do, because this is an area that's hard to quantify, like you said, if we put money into, say, we do a study that's targeting, say, 2 age groups, maybe kids when they get right out of high school, and then say at age 25 or maybe closer to 30, and have a well-designed survey, basically, to kind of get a baseline for what kids know about drugs.
Yeah.
What do young adults actually know? I suspect they know more than we think they know. And there's probably, it's probably, there's a wide range of beliefs. And I think if we could get a baseline that was fairly stable, have it as a program that's going on year after year, to measure whether or not any of your programs for education are actually having an impact, but also just from a data point of view, I think it'd be really interesting to see.
Yeah, I do too. I'd be curious to know that. I think that that we know now that the other pillars, like the pillar of enforcement, has not had the impact on prevention that they thought it would.
Yeah,
in terms of stopping young people from accessing or experimenting with drugs in the first place. And I think a trip into any high school would probably uncover that pretty quickly. And certainly in my era of going to high school, and that was sort of prior to some of these revisions being made, it didn't slow things down at all.
No, quite the opposite, actually. And it's not hard to find stats that support that. It's well known that is that part of enforcement there's been no discernible impact on prevention. So, I looked for a while, and that was, I couldn't find anything else that was really tangible as far as strategies that were being implemented.
Yeah. The thought that I kept having as I was thinking about prevention was that, we've talked about the phrase that's a fairly well-known and well-accepted phrase now, that the opposite of addiction is connection. Yet all of the drivers within our society are leading us away from intimate interpersonal connection, and it's so much of the connection occurs behind screens. And we know now that is not the same type of connection through social media, for example, which, to make a bit of a generalization, but if you think about how just ingrained in society for our young people that is. So when I was thinking about prevention, I thought, well, what if it was a more regular class or a more regular part of our education system, where it wasn't just like you go to a gym class and they've got the blackboard up about what types of drugs are out there and what could happen to you and the risks and stuff. But what if it was done in a more of the style of some of these peer support groups, where there was open conversation, and maybe it was peer-led conversation, or at least conversation that was led by a non-authority figure, where there could be really frank discussion about mental health and about illicit substance use without the fear of repercussion.
Yeah, that's a very interesting idea. If you got kids to, I don't know what would be, I think back when they were trying to, they were still using the DARE program. I think they hit you with that somewhere around grade 7 or something, and you're 6 or 7. That's when they think you're going to be vulnerable, and when you're, mature enough, I guess, to handle it. But obviously, we know that was a complete debacle.
Yeah.
But yeah, why not? I mean, we're having so many mental health issues, and especially with the kids that are coming up, their attention is broken into a million different pieces with social media, and that's like they interact like they're wired. They're already half AI. It's
sure.
So yeah, what if you got them away from their devices for, say, every day you did a 30-minute sit down with, I don't know if maybe you could have a group of a certain number of kids, and then that would change up every month or something. So maybe if there was somebody in your group that you didn't feel comfortable talking with, at least somebody else would, you'd get changed out, so you'd have an opportunity to discuss or be more open the next time, type of thing. Yeah. And if it was just, if the teacher took a role of simply kind of standing back as a facilitator and not actively being a part of the discussion, that could be interesting.
It could. And, for anyone who thinks, well, I don't want my child having a frank discussion about drugs while they're in school, they probably already are.
Well, of course. Yeah.
Of course they are.
You can't hide from the problem, and you can't scare kids away from the problem. It's not, I don't know, you think back to the way your mind works when you're a teenager. They don't think in those terms. It's a very now-centered vision, and mortality is not something that's on your radar.
No.
But learning from each other, I mean, that's what kids do anyway, right? That's where, like, to me, when I look at high school, okay, well, the stuff you learn in there, I mean, you could probably condense it into a year or two, right? If you're really serious about learning that material. But the other stuff that you learn there in that atmosphere, as far as how to act socially, what you can tolerate from people, your patience level, all those little things that you can't just read a book to understand. Those are the things that, a lot of those things are life lessons that shape you for a long time. So I wonder if you could use more of an angle like that to have a greater impact, at least like, we don't know, like, people are never going to stop using drugs. I mean, we can say that with a fair amount of confidence. This is just, human beings have been using drugs since we've kept records. It's just, there's a desire to change our perception. It's innate. Some more than others, and of course, some people go too far with it. But you would have to think that having more realistic knowledge at a younger age and having a better grasp of that would have some kind of an impact. For example, look at how often we see kids who grow up with alcoholic parents who stay away from booze. because of what they've seen. They didn't learn that in a book. They were witness to the destruction of that problem when it's unmanaged, right?
Yeah.
So yeah, that's a really good idea, man.
It's an interesting discussion, and because I think if you think about imagining conversations that are happening within the hallways of a high school, and if a principal were to overhear a conversation about buying some ecstasy or buying a bag of pot, and hauling those kids into the office to give them a slap on the wrist or suspend them or whatever, will only push them underground. Will only stop some sort of a dialogue from happening. A dialogue that could be more honest, that could be, get to the real root of where that's coming from, and bring it out into the light instead of pushing it into the shadows. It's
a dialogue that could save a life.
It could. Right?
And actually, we should mention that is one thing that when we get to harm reduction, that they've changed. The government has changed in BC. I'm not sure if it is like this in the other provinces, but there's a protection law now for people who are requesting help in drug overdoses, that they can't be persecuted for drug possession or anything to do with drug paraphernalia. And that's exactly why, right? It's the same situation. You need to be able to tell that principal if your friend is dying so they can get help.
Yeah. Right.
Yeah.
Exactly. So Nathan, can we ask the same question within the world of healthcare? What is being done in terms of prevention for healthcare workers?
Well, I'm sad to say, but I would say the answer to that is nothing. I mean, even though you can look back at how many times the health ministry has claimed that they're going to put money and research into, they always say that they're working hard to make the workplace safe, right? And then okay, what are you doing? And we've secured these sharps containers so that you can't break into them anymore. It's always something like that where they take something that's existing and they tweak it a little bit, and there's never any reference to, did it have an impact? Was there any work done to see if this is actually helping anything, or where is the data coming from to support this as a method of prevention for healthcare workers?
Yeah,
I don't see it. What's your thoughts on that?
Very, very similar. So, I've been hearing that for a good part of my career, that they were looking at changing the way sharps containers. And for anyone who doesn't know, we're talking about bins where needles or vials of partially used or empty vials would be discarded. I've been hearing about that for a long time, about changing the mechanism and changing the structure of those bins to make it safer and make them more impenetrable. And then there are also different safeguards put into our drugs dispensing machines that, first of all, records are kept, and there are flags and warnings that come up on them. There are also things like requiring 2 signatures to waste medications. So all wastes have to be supervised by a peer. Now, are those preventative things? I think they would say yes, they are. But I agree with you. I would challenge that they are structural means of prevention, but they're not prevention in a larger sense.
Well, in every situation that I've come across throughout this problem with the healthcare workers who get into trouble this way, especially, how many nurses with the hydromorph? I don't know. I think if most people understood what was going on just on a volume capacity, where they saw how many, it's like a turnstile of nurses going to treatment and coming out and going to treatment and coming out. If you have somebody who wants to use that medication and it's available in any way, shape, or form, and these are, healthcare professionals can be pretty determined, I think, and for the most part, fairly intelligent folk.
Yeah.
They're going to figure out a way, so these types of prevention methods, they're not going to cut it, and they're without any measurable data. How would you ever know anyway?
Yeah. And the question that, to me, that where our system it falls short is in saying, how come you have thousands and thousands of employees? What is different? What is happening to those few and growing number who do? And for myself, I look at what flipped in me from the time, where I was working amongst hydromorphone for years and didn't consider it. And then it came to a point where I did. And to me, it's not that different of a conversation than what we were just talking about with high schools, that maybe you start with an increased emphasis on peer support and on dialogue and on mental health. And maybe that's what true prevention for our healthcare workers looks like. And, we've talked in the past about the role that debriefing has, for traumas, which is great, but that is incidental, and it is usually a singular conversation, and it is not maintenance.
No, and from what I understand, it's barely implemented to the level that it's not even at what was recommended in the beginning, and that many nurses don't have time to stop and debrief. And if anybody knows a nurse that's working in BC right now, they will tell you that they don't have more time right now. They don't have more time than they did 5 years ago or 2 years ago. They are busier now than probably ever.
Yeah. And if you think about sick time and the use of calling in sick for a mental health purpose or for a burnout purpose, it's not, there's a list of options when you call in sick. There's a list of options that it gives you. Press 1 if you have a respiratory illness, or press 2 if you have vomiting or diarrhea, just so they can track, so the employer can track why people are calling in sick. There's no option for mental health. There's no option for burnout. And why wouldn't we want to know that? Why wouldn't we want to track that? And not only that, but then if you are inclined, if you are an empathetic, sensitive person, things that we've talked about in our previous episodes, and that your team will be short-staffed, and that your team will be that sick call for your mental health probably won't get filled. Your team will probably be short. That is a deterrent, and that is for many, that is a reason why they wouldn't call in sick. And so they try to push through. And if you don't think that there's a connection there between that sustained sense of burnout and sustained wear and tear on your mental health and turning to a substance to cope, then you're wrong. You're wrong.
Yeah. And it's a great point, because it's a vulnerable upstream access point that could be improved greatly with very little money. Just even to start tracking. I mean, like you said, this could be set up on a phone tree system where you're keeping track of who's calling in and what the purpose is, and collecting that data, and then at least you've got a baseline to work with. Actually implementing, I mean, say somebody calls in, you see that they've called in for mental health issues 3 times this month. Maybe some sort of alarm should go off somewhere, and that individual should be checked on.
Yeah.
What's going on? Like, have a sit down, and that would be a great time to roll out the person that they should have seen probably 3 times already for a debriefing.
That's right. I mentioned this, I think, in my introductory episode. I remember one specifically horrific incident that I was involved in, and it happened to happen within 6 hours of my first shift on a set of 4 shifts. And I went through that incident. I finished my shift, and then I came back for 3 more. And there was a debrief on one of those, but the message that I received for toughing it out and being there was, "Oh, you're good. Oh, way to go, way to help the team." And true, but that there's not a there's a price to that.
Yeah, it's the wrong type of encouragement. That's got to be kind of I get the pat on the shoulder there, but you don't want to pigeonhole somebody by making that the culture, which it is, right? But you've got to leave the door open so that people, they can't feel like they're letting their team down when they're asking for help.
Yeah, and particularly with what is happening in our country, in our world, and in our healthcare system today, and over the last couple of years, it's we're in the crisis. It's we're kind of too late for prevention now. I think we can look forward and look at how we change this moving forward. But that dramatic effect on folks with burnout and with the deterioration of their mental health and the lack of support of their mental health or allowance for that's already happened. And now we have to kind of try to rapidly catch up, I think.
Yeah, we're going to see some pretty desperate situations here, regardless of what happens now with the pandemic and onwards. If from what's already been done, how hard we've pushed the healthcare professionals in the province, this will affect us for the next 5 to 10 years at least. With
absolutely,
people, just with mental health, with retiring early, with switching professions. I mean, you think it's a desperate situation now? Give it some time.
Yeah, or if you have any young folks or people are in high school, say, who are considering entering the world of healthcare, if they caught a glimpse of what's happening, or if they had a conversation with the right or the wrong healthcare professional, they would say, "Holy shit, I'm running and not walking."
Yeah,
away from this.
Yeah, absolutely.
So, again, we could talk about that at length because it's such a prevalent issue. But yeah,
indeed. What about what's the next arm there? They look at treatment. So, treatment options for the general public. If you know somebody who's tried to reach out for help, that can go. You can if you call at the right time, or you are lucky to be in the right place at the right time. Lots of times you can get a hold of somebody who can direct you to a center. Sometimes, if you're really lucky, it will be in BC, at least, provincially covered program. There's quite a wait list last time I checked for provincially covered programs, but if you have the money, you can definitely get into, like, if you're looking for an inpatient treatment or outpatient treatment program, that's certainly an option. But there's many forms of treatment for the public out there. I've got. Did you look into that much as far as different options, Corey?
Well, the thing that I landed on too was accessibility of these things, and that it's greatly dependent on cost and dependent on income, and if you or your family can swing that. We've talked a lot about treatment centers in our past episodes, as they pertain specifically to healthcare workers, but that can certainly, I think that the experiences that you shared, Nathan, would be pretty universally accepted as being common amongst people who are not within healthcare too. That it's pretty varied and varies greatly based on how much money you have to put into it.
Yeah, absolutely. I mean, you can go from $12,000-$13,000 for a 35 to 42 day treatment stint, all the way up to, I mean, there's ones in Canada that are 40 or 50,000 for the same amount of time. And it just depends on how much money is being spent on the level of the credentials of the people who are helping you, the setting. Some of them are quite luxurious. And yeah, I think we know that there's differences between treatment centers, and sometimes it's not even money. It's just for whatever reason they've got a good collection of people, and another place doesn't. Some places have a bad reputation. Some places have a better reputation. That's kind of how it goes with the treatment centers that I've seen, anyway.
Yeah, and there are also another option, at least within our province, are detox facilities that are short stay facilities for drying out, for detoxing from alcohol or drugs. But then you're on your own. Like this is short stay. This is not, and it is not embedded with a rehabilitation program. It is just it is a life-saving place for many because it offers supervision and support while you are detoxing, but it's not the same as a treatment facility. That said, 10 years ago, there weren't the number of detox facilities, at least in our province, as there are now.
Yeah, certainly there wasn't the need 10 years ago that there is now. But yeah, you're right. It's detox centers they're usually used as a step to get you functional enough, or at least clean enough to go on to the next kind of series of steps that lead you towards treatment. Basically, they keep you alive. Yeah. Yeah, I wonder why it's 5 days now that I think about it. And I guess that's it probably is based a lot off on of the more serious conditions, right? Like the withdrawals that can kill you, like alcohol withdrawal. Probably if you can get through 5 days, you're most likely stable.
But still feeling pretty rough, and still
you're going to feel rough, yeah,
and high risk, yeah. And not necessarily out of the woods, but I've certainly seen folks who it takes longer than that, or after 5 days they're maybe barely functional, depending on the sort of how extreme their circumstances are.
Yeah. I basically looked at a lot of different programs that you can choose to be a part of on your own, or that are offered in some treatment centers, like we use cognitive behavioral therapy lots, dialectical, motivational enhancement theory, psychodynamic. These are all, it's talk therapy basically, and you're going to find that along with all the myriad peer support groups that are out there. Those are all available options. There's medications that we know help, obviously, not just opioid replacement ones, but like I've discussed with the Sinclair method, using naltrexone and even acomprosate, and what did they used to use? Antabuse. They used to use one that makes you throw up if you drink when you're taking it. Not very, not commonly used. I've never seen it prescribed, but it used to be, I guess. I think it had a little period of time where people were trying it. Lots. Disulfiram, I think it's called. And then they're starting to do, I read a story. There was an article on a guy who, like, he made it to age 35, in and out of treatment centers his whole life, ever since he was introduced to a drug, he'd been going, like, he just seemed to have no control over the situation whatsoever, escalated all the way up to meth and fentanyl, and exhausted all his resources, basically considered himself to be a lost cause. And he ran into a program that was being offered. They wanted to do, I guess this is, they use deep electrode stimulation in the brain directly. They've been using this for Parkinson's with good results for quite a while, I think. And this is I'd never seen a study of somebody who'd had that done to try to help with cravings and withdrawal. But they used that for this guy. So they've got, I think there's 3 different areas. I believe it's in the nucleus accumbens. So that area that's very much part of the reward pathway. But he can dial up or dial down kind of his anxiety levels, the way he kind of processes things. If he has a craving that's bad, he can go in and they can adjust it. It's pretty interesting, and it's not I was looking at it, I was like, oh man, maybe that's the cure, right? But it's still, it helps a lot. Like it's actually stabilized this guy, and he's been able to go back to living a normal life. He's got a family and everything. His life is stabilized, but they did it with a couple other people. Didn't work very well. I think the technology's only going to improve, and I've thought about, wouldn't that be nice if you could just go in there and dial some of these things back and forth, right? Like, I mean, if we're going to live in this kind of society, isn't it almost necessary that we have some kind of attenuation? You know what I mean?
Yeah,
we're not out wandering around in the savannah anymore. Okay, we don't need to be. We don't need to have these kind of levels of anxiety, or maybe we do, but it doesn't seem to matter anyway. As far as like, just because we're anxious doesn't mean we're doing any better, right?
No, exactly.
So, yeah.
Well, I mean, it sounds at first it sounds a little sort of like a Stanley Kubrick movie, or like something that Elon Musk is probably currently working on. But really, how different is that from pharmaceutical control or from other treatment options that we've talked about? I'm not sure that it is.
It's not different.
No,
I think it's. I think you're looking at a procedure that is eventually going to be far more precise than pharmaceuticals will ever be, far more specific, as in targeting. If you've got a problem with serotonin, synaptic cleft, downregulation, upregulation, whatever you want to do, they'll be able to fix that.
Yeah.
You don't have enough vesicles coming out at the end of your synapse. Let's make some more. I mean, you could, you think ahead and you look at not a simple device that's incredibly, that's very complex, obviously, to put one of those in somebody's brain, but getting to the point where you're adding maybe a stem cell bio component to it, and this turned into something that's, cyborg style brain device that's actually fully controlling your mood, which would be kind of scary, I guess, eh?
Yeah. Yeah. There's yeah, we're not there quite yet, but yeah, who knows?
Yeah. And there was one more device that was like that called a NSS2 bridge. This is for cravings as well. And it's the same type idea, but it's not as invasive. So it's just you wear it behind your ear. And I think it's contact to the tympanic membrane and the bone that goes behind your ear there. Somehow it works to uses electrical impulses as well and decreases cravings in acute withdrawal. And it's interesting. It works. It's successful, but it only they can't get it to do anything for post-acute. So I don't know why that is, but they're having some success with that.
Interesting.
Yeah. So I just thought I'd throw out some weird ones there for you.
So let's, I mean, this is probably the biggest one right now in our country, certainly in our province. It's the one that has opinions have changed probably the most drastically around, which is harm reduction. This conversation now would be a totally different conversation 10 years ago. And probably in 10 years' time, it will be very different than what we're talking right now about harm reduction.
I hope so.
Yeah. So the question we had said was, is harm reduction in Canada being implemented effectively as it stands? Is it working, do you think?
Well, I'm going to give Canada a generous C on this one. And that's because we've seen a lot of progress with supervised injection sites, supervised consumption, and not just the implementation of these strategies, but the implementation of them because we're seeing success elsewhere. This is, I think, what most people who are watching this unfold, I mean, that's all we're looking for here. We know that some of these programs have had great success in other countries. So why are we not using them? And when we follow that when we follow the lead of like the Netherlands and like we have, where, is it England? I think it's England who did they started with heroin, giving injectable heroin as an option for people who are in the methadone program. And that has there's a certain percentage of people who just don't do well on methadone for whatever reason. And that percentage has done great on supervised injection of heroin. So, I mean, what this is all tending or trending towards is the responsible use of drugs. I mean, that's kind of where this is headed, right? And I like to see that stuff. So I'm happy with that as it progresses, where we have a long ways to go there. What I don't like is they've made some adjustments. When did that happen? Maybe 5 or 6 years ago. I don't know if you remember, where they made an adjustment to the methadone program where they capped the amount, changed the potency. A few people died because of that. I still don't really understand it. I guess their idea is, if you're gonna cap your limit at 100 milligrams, then why would you change the potency? Like, I mean, I could understand if you were going to keep it. I had patients. I've had patients on 360 milligrams a day, and in the old form, you're almost drinking half a liter of methadone a day. Yeah. I mean, the patient has to come in there and sit down. They're going to be a while, they drink this whole jug. So for them, it would make sense, but then they capped it at 100. And I don't understand why you would cap a drug that has no therapeutic ceiling. Like, we know that there's a great variation genetically between people, the way they respond with these type of drugs. So, either do it or don't. I don't understand.
No, I don't either. And I think a lot of people don't. And all of the reading and research I've been doing leading up to this is that there's a direct correlation between this particular issue with methadone and the current overdose crisis. Is that the cap on methadone and the change in potency puts people in a position where they are still experiencing cravings and withdrawal symptoms, and are doing something called chipping, where they go and top off their methadone dose or with heroin, or in many cases unknowingly fentanyl, and that is what contributes to all of these deaths that are happening. And to me, the question about how serious do we want to get about preventing these deaths that are happening in our country and in our province, if that is the goal, if saving lives is truly the goal, then we've got to relook at methadone. And then, like you said, we have to look at safe supply. And those just seem like such no-brainers now that we know that, stop making it so that people don't have any other option but to go and buy it on the street, where they don't know what they're getting. And I mean, you and I have talked about our own experience, and I really think that for myself and for you, our decision that doesn't make us any better than anyone who decides to go and use drugs off the street or buy drugs off the street. But that was, both of our decision was to stay within our quote unquote safe supply. And that's why I'm alive. That's why I think you are alive, is if nowadays, if you are going to a supply on the street, you are rolling the dice.
Absolutely. I mean, back in the last 5 years, I've lost at least 2 people that, I would at least talk to on the phone once in a while, like not close friends, but people that I know well, just from cocaine, just from recreational cocaine use that was laced. That's not even people who are going out and looking for an opiate. The risk of death is so high that, I just don't understand. Like you said, if the goal is real harm reduction, then why shouldn't the metric be how many people are dying and how do we fix it?
Yeah.
I mean, there's talk of, well, if we, people don't like injection sites, they don't like supervised sites. All this, we have tons and tons of data about what happens when you provide people with a safe supply. And it's not what you think. The crime in the area actually goes down. The trips to the number of ambulance calls dramatically decreases. Of course, the number of people dying decreases. There's just a general calming effect in the whole. I don't know, you put a center there. I don't know how much of an impact it's going to have. I guess it would depend on population density, but we know what the kind of impact it is, and it's a positive impact.
Yeah.
They did ran the Naomi trial back in it was 2005 to 2008. See, this is another thing about Canada that I shake my head, because we're the only country that did this. The rest of the people who ran this trial, so there was a bunch of studies done to see what would happen if you put together an injection site, supervised injection. So they're tracking what would be the response in a whole bunch of different parameters. And then they also wanted to see how a hydromorph, just injectable hydromorph, would hold up against heroin as a substitute. And lo and behold, in this study, at least, I've seen it, a couple that were maybe questioning the validity of this, but in this study, at least, most people either accepted hydromorph as an option that was just as good as heroin, or even preferred heroin. So there was no, and from a federal standpoint, that's a lot easier for us to deal with as a country. Hydromorph is cheap. We can supply that. It's got a nice high potency, so it's probably easier, even from a logistics point of view, just for distribution and stuff like that. So there's a trial where it shows that the people who are involved in this trial, the individuals who were given the supply, their lives improved dramatically. They spent there was way less physical harm going on in their lives. Their personal life stabilized, less crime, less jail time, blah, blah, blah. The list goes on. So every other country that did this study, when the study ended, they're like, well, we can't stop. These people are doing great. We're going to continue this study just for the people who are in here until we figure out what to do. Canada, no. Study's over, guys. Back to the street. I mean, what kind of lunacy is this?
Yeah, right? And I wonder how many deaths occurred within the first month after the cessation of that program.
Who knows? But no, because nobody's tracking it, right? I mean, it's crazy stuff.
Yeah, I mean, again, and I think we now know, I think it's pretty universally known about fentanyl, about what that, what the potency really, what the impact of that potency is. But if you just looked at the incidence of people requiring Narcan in supervised injection sites or in the streets, on the streets, it would be just infinitely less with the use of hydromorphone. The other thing I was going to mention were the naloxone kits that have been distributed, and these are distributed within any of our communities. They're distributed at the safe consumption sites, in shelters, outreach teams, and in hospitals. And that's great, but to my knowledge, the naloxone kits come with 3 vials of naloxone with fentanyl, or some of the more potent strains of fentanyl. It's inadequate. Whereas again, if you created a safe supply, still provided those naloxone kits, that would be the amount of naloxone that is provided would be from inadequate to excessive, really. And the overdoses just wouldn't occur in the first place, I don't think.
Yeah. There's a reason why this is happening with the potency, and it has to do with enforcement.
Yeah.
Which I guess we can.
We were going to mention just quickly, Nathan, about harm reduction in healthcare.
Right. We did want to look at that. Yeah.
And there's a couple of interesting points there. Is harm reduction in healthcare a feasible thing? Does it exist?
Okay. Yeah. I'm glad you brought me back to this one. I was ready to forge ahead. It does exist. Here's my understanding of the situation currently.
Yeah.
So if right now there is healthcare professionals in Canada who have been given the okay to practice well on Suboxone. This was absolutely not a thing just a few years ago, but it's on an individual to individual basis, and still many programs. Like I haven't seen any nurses. The nurses, I don't know what part of it they don't want to. They don't like. I guess there's the idea before was in pharmacy, at least, they were concerned with the pharmacist's cognition level. The idea was if you're on Suboxone, you're not going to be as sharp as if you're sober. So the pharmacists who were looking to have this as an option offered to do the same requirement tests. Is it okay? Well, examine us when we're taking Suboxone, and if we're fine to go, then what's the problem? So they thought about it some more, and they decided to capitulate. And okay, we'll let you do this. And there's no problem, because it's not with all you'd have to do really is look to the States, because they've been doing this for a long time. Lots of doctors down there are working on a daily basis on some kind of opioid replacement that's been going on down there for a long time, at least my understanding. So this is happening, but it's still relatively rare, and it's certainly the exception to the rule.
Yeah.
So I think it's something that's changing, but it's a weird thing in that if you talk to people, I think both of us were offered Suboxone at some point when we were early in treatment, and we both turned it down for obvious reasons. We both considered ourselves to be past a point of needing that.
Yeah.
But had we not, then you've just picked up something else that you're going to have to deal with. Like it seems absurd to me that it would be offered and then also a barrier to practice.
Yeah, I said that to you the other day. I think it would have, to my knowledge, derailed any movement that was occurring with getting back to work or with moving forward within the system. Like I think it would be a huge. It would just sort of grind things to a halt.
Yeah, which is so strange, because the rhetoric the whole time is, oh, we're going to get you back to work. Don't you worry. Everything's going to be fine. We'll get you back to work. And I don't want to go back to work. What are you talking about? Are you crazy? I'm not going back in there. Oh, yeah, we'll get you in there. We'll get you there. And then you get to treatment and like, oh, here, how about some Suboxone? You get out of treatment. Okay, now I don't want you taking like no cough medicine. No, I mean, the only thing, no antihistamine. You're not allowed to have a Gravol. The only thing you can have is caffeine, and they let you smoke if you're into smoking. So it's, what a strange message or a series of messages to receive. So
very confusing.
Very confusing. And I'm not sure, I guess we'd have to look into each profession and probably contact colleges. And then you'd have to look at the unions, the colleges. You'd have to talk to everybody basically and find out where they're at with that.
Yeah. I'm also aware that there is, and this is a bit of quite a different circumstance, but I know that the use of things like Adderall and Ritalin and those stimulant drugs, which are available by prescription, that do certainly have a mood altering effect, and I know can be used by anyone, but let's say by a healthcare worker with a prescription. And if they weren't sort of put into the machine, so to speak, they would fly under the radar with that and be functioning with a pretty potent stimulant on board.
This is something that gets a little bit ridiculous when, I think it would be interesting for the general public just to have access to the information that a pharmacist has access to just for a week. just to get a feel for, if you're one of these people who ever felt bad about taking an antidepressant or felt bad because you're on medication for ADHD or something like that, I got news for you. Everybody is on sleeping medication of some kind. Everybody is on an antidepressant, and everybody who's working more than like 6 hours a day is on a stimulant. Okay. This is how our society is running. If you take those things away, you're looking at a zombie apocalypse, in my opinion. I mean, it was shocking for me to see, and it's not just the people on income assistance. It's everywhere, up down the board. Everybody. There's no exceptions to how ubiquitous. It's not that not everybody is on all of those, but man, most people are on at least some of them.
Yeah.
You look at that, you think, okay, so everybody's either anxious or depressed. Nobody can sleep, and they're so tired that they've got to take a stimulant to get through the day. It makes you consider, or at least ponder, what kind of a direction we're trending in here.
It's true. Yeah, it's true.
So yeah, I guess we can look at the last leg.
Let's do it. So enforcement. Has enforcement in Canada had any measurable impact on production and distribution in Canada?
So this is a very difficult stack to track down. The general kind of I guess the general kind of consensus is that enforcement over the years, regardless of the program implemented or the money spent, usually is good for capturing or intercepting about 10% of all illicit drugs that are either manufactured in the country or outside that are getting in.
Yeah.
So it doesn't matter. We tried spending tons and tons of money on it. The states tried to spend tons and tons of money on it. And what happens is, it's interesting with what we were talking about before with potency. It's they have a word for it. I think it's a iron law of prohibition. I think it's called iron law. So what they noticed was the more money that was spent on enforcement and the more rigorously, strictly, like the more police they put on the ground, the harder they made it to get drugs into a population or into a country, the potency of those drugs increased. And the reason for that is simple. It's easier to smuggle a more potent drug. So if you look at what's happened, we went nuts on trying to stop heroin from getting into the country. All of a sudden, they synthesizing fentanyl became popular, and then it turned into W18 or carfentanil. So you've got something that is, fentanyl's 1,000 times the potency of morphine, and carfentanyl's 1,000 times more potent than that. So, I mean, some of these drugs, like carfentanil, I don't know how you even, like, how could you work? How did they make this stuff in a clandestine lab? I mean, these labs are probably extremely high tech, but I mean, if you inhale a molecule of this stuff, you're down.
Yeah,
like in pure form. So, I mean, you think of the fentanyl's bad enough, but something like that, I mean, you could have an elephant walk by and have a little bit hidden, inhaled or injected or whatever, and that's it. Like, it's beyond comprehension that could be a drug of abuse to me, and yet this is where we're at.
Yeah, and we're not talking about the old-fashioned looking bricks of drug, and that's what you're saying, is that it's that much easier to smuggle.
Exactly. Yeah. So I mean, as technology, the more money we pour into technology to try to break down the organized crime as far as distribution and trafficking is concerned, every dollar that's spent, they look at it and they go, okay, well, what you've done is you've increased the incentive now. So it takes, to be a successful criminal, to distribute this drug, takes a lot of resources. So the price of the product goes up and the potency goes up, and it continues in that direction until the pressure is relieved again. To me, I mean, this is a no-brainer. Like, you want to get rid of this stuff? Just stop with the nonsense policing, get enforcement right out of there, make it all treatment, harm reduction, education. Get the police doing something that is going to actually have an impact and not put them in harm's way. That's the other thing that happens with increased enforcement too, is increased violence. It's a metric that is always the same in every situation. You look at when Mexico declared war on the cartels. I think the first year of that, they lost 55,000 people in that country just to, back and forth, straight up military conflicts.
Yeah.
The Philippines, same thing with the president they've got there. He's still on this nonsense war on drugs kind of attitude or whatever. And way more people have died since he's implemented that program than before. So just from again, if you're looking at violence and just straight up death numbers, it's not a good scene.
No, and it feels like we're sort of doing it. I think saying halfway might even be generous. But I was going to say, halfway in that we are putting money into harm reduction in this country, not doing the full step of harm reduction yet until we start looking at safe supply. But there is some credit due there. There is, I think compared to where we were 10 years ago with mandatory minimum sentences, that has changed a bit in this country too. But there's still sort of opposing forces happening there. That the end result is driving people underground and pushing people into, out of the light.
Yeah, exactly. And I mean, if you look at somebody who's involved in the drug trade at that level, you are not living an existence where the normal rules are even useful for you. I mean, if you have, say, your rival business competitor does something underhanded or whatever, what are you going to do? You're not, a normal person, a law-abiding citizen. We would take if we had problems with somebody, usually you try to go to court and settle it in court in a peaceful way. When you have an entity that is policed at that level, you cannot afford to do anything other than you're all in, right?
Yeah.
That means you're killing your way to the top and you're doing what it takes to stay out of jail. So you can't have a half measure over here on this side when the other side is all in it to win it.
Yeah, exactly.
So yeah, it's a funny thing. It's like these measures they're all political kind of placations, right? They're just, I don't know if that's even a word, but they want to appease a progressive kind of more liberal crowd, I guess. But at the same time, they don't want to upset the more old school kind of conservative viewpoints. And I know this is the way things work in our society, but man, why can't we just look at the numbers, look at what is actually working in other countries? I mean, we don't even have to do anything groundbreaking here, for God's sake.
No,
just follow the information that we've seen work elsewhere. That would be a good start. And like I said, I mean, it's not like there are programs that are doing that, and I applaud that. But we got to do so much more if we're ever going to stop this.
Yeah, no, it's true. It's true. And the savings alone is astronomical that could occur here.
Yeah, probably people out there are thinking Portugal. Why did you guys mention Portugal? But yeah, that's a great example of just a common sense approach where they looked at the situation and like, you know what, this isn't working. Let's decriminalize, take the money that we're going to save in court costs and policing and put that into education and treatment. Lo and behold, their numbers are tracking in a better direction. I mean, it's not a mystery. as to what's going on here. It's just, and that's not even legalization. That's just a move in the right direction.
Yeah.
You know? So yeah, I mean, who knows? It seems crazy, man, where this is 2022, right? And look at us still with the war on drugs.
Yeah. No, that's right. You know, I wrote down a statistic as I was preparing for this that, you know, talking about the disparity of race in our prison systems. You know, that Indigenous people make up 5% of our population, but account for 30% of the incarcerations within our country. Mm-hmm. And there's a similar statistic for Black Canadians.
Yep.
And that comes right back to enforcement, and well, enforcement going down and harm reduction going up would change that entirely. And looking at I think looking at how we understand the problem too, and where we are putting our attention, and what how much we allow politics to drive our these factors.
Yeah, absolutely. I mean, it would be interesting to see if all of a sudden we were able to implement a bunch of policies that just withdrew, it redirected our police force, redirected our legal resources, and took all those dollars that weren't spent there and then put them into improving socioeconomic factors that probably contribute. I mean, harm reduction is obviously going to help, but part of harm reduction, like you said, is going to be improving people's lives in general, from starting from the ground up, giving people at least a chance or an opportunity to get out of a poor community, or to have at least a kind of more of a even starting. You just want to give somebody a chance at starting off in the right direction.
Yeah.
And that's something we can definitely do a better job of too.
Yeah. And there's so much more to that. And the social issues that come hand in hand with that will take years to look at, and years for Canada to address. So I couldn't pretend that I have all of the solutions to that. But
no, that's a very complex problem.
But what you are doing by changing some of this model, as we're talking about, is that you're freeing up money that could be spent elsewhere, and resources that could be directed elsewhere, and communities that could benefit from that. And there is that's sort of where the connection can be quite easily drawn and easily seen.
Yeah, I think so too. And I don't think it would take a tremendous amount of time. Like you could set a timetable and have your marker set for when you want to implement each change in a gradual fashion, so that adjustments could be made. And I know, on a province-wide, from a province-wide perspective or a federal perspective, all these changes take a million years because of the way our government works. But we have to at least be, speaking up about what direction we want to go, I guess, to start with. And then, and I know lots of people are definitely with the opioid crisis, but man, it's disappointingly inept, disappointingly slow.
Yeah, it is. Yeah, as daily numbers in deaths rise.
Yeah. And I mean, this is like, we've had so much time to adjust now. It's just, and yet, it really makes me wonder if I'm missing something as far as what the motivations are, or the lack thereof of motivations. Like when I see the amount of coverage that we got throughout the pandemic, just from a media point of view, I look in the news and there'll be maybe, I tried to estimate it, I think there's probably 100 news articles on that for every one about the opioid crisis.
Sure.
And yet the opioid crisis in BC, at least, is claiming more people between the age of 25 and 49 in their productive years by far. So what is it about, you would think that we would look at that and say, okay, we have to put at least as much effort, spotlight, energy, resources, whatever, into that problem. But it's not even close. If you look at the money that's been poured in, it's not even in the same hemisphere.
No.
So, you got any thoughts on why that might be?
I think, I as you were talking, the thing that came up for me was what if you combine the numbers of overdose deaths with the numbers of suicides? And that there, in some ways, it's two different conversations. But there are similarities in that there's a lot of taboo there. There's a lot of stuff that people don't want to talk about there. And, I think, it sort of speaks to our tendency to go towards the easy answer, or society goes to things where we sort of pat ourselves on the back for starting the conversation. But I don't think the conversation very often gets finished and gets really, really flushed out. And, yeah, I mean, I don't know. Do you think that if we combine those two numbers, overdose deaths and say suicide among the 20 to 40-year-old population, would seeing that, would grouping them together with mental health, would that benefit? Because to me, so often addiction gets talked about separately from mental health.
Yeah, maybe that's part of the problem, I guess, it's kind of a amorphous topic, right? It's hard to, I mean, you can say the words opioid crisis, but if you're to try to tackle the problem, like it's not about instituting, silly policies that can be like, okay, when you go into a restaurant, you have to put a mask on until you sit down. And then, things that can, at least when a politician puts in a policy like that, at least they can say to their constituents that they've proactively done something. But in this case, I think it might be harder for politicians to get active kind of PR points out of the amount of attention, work, manpower, whatever, that energy that they're going to have to put into the problem to have an impact. And maybe it's as simple as that. It's not good political bang for your buck.
That's right. But we sort of give a surface level of credit to a kind of a generic or safe tweet or Facebook post or something that can kind of generate some support. But what is it actually? How does that actually translate on the ground? And for communities in our country that have astronomical suicide rates or astronomical rates of overdose, and a lot of those are Indigenous communities. Like, what is that? How does that what that politician is saying that gives them the pat on the back? What does that mean to them, to that community?
I would imagine it is an insult.
I would too. Yeah, I would too.
If I was in that position, and I'm watching my community, I've lost my uncle, my sister, my two friends down the street, and there doesn't appear to be any kind of, nobody's showing up, nothing's happening, and yet this politician is trying to side themselves on the correct. They want to be on the right side of history as far as this is concerned. Yeah, that would be infuriating.
And it's kind of the same thing that's happening within our population of drug users and illicit drug users, that these deaths are happening rapidly around us, and we're still having the same debate on a government level and on a social level that are we okay with handing out a safe supply of drugs? And is there a ceiling to that number where people will say, okay, now 5,000 people have died this year, now it's time?
I often wonder that. How many people will it take? Um,
and then we wonder why people are on the fringe, or why people feel alienated, or decide that, hey, I'm still going to live in the downtown east side, or live in my community that is rampant with social issues and with crime and poverty and all the rest. Because I would, how do they not look at the system and say, fuck you, you failed me.
Yeah. And I think, unfortunately, that component of it is maybe in rougher shape than it's ever been in our lifetimes, for sure. Yeah. There's less general trust in our regulatory bodies and our government than I've ever seen. And I mean, it's crazy to say this, but I'm having a hard time sometimes coming up with good answers, as far as it seems like it's harder to find good data now on, just on pharmaceutical questions that I get. I find that I'm being blocked from things that I should have access to. I'll either have to pay to get access, or the information that I get is of poor quality. It's and I don't know if that's my imagination, but it almost seems like there's more barriers now being put up, so that it's harder for me as a healthcare professional to even access the data I need to be able to make a decision. Mm. And then you put on top of that the nonstop stories and controversies and scandals from like the drug companies. I mean, the amount of money they're paying out in lawsuits, it's hard right now to look at anybody who's in control of these sectors and say, yeah, they're going to figure it out.
Yeah. I think there are some changes being made, but and I've said this before, but I think that a lot of the changes will happen in spite of the establishment and of the system, and not because of it.
Yeah, you might be right.
Yeah.
So I guess looking at these 4 pillars of our since 2016 strategy, and one that's supposed to be more tailored toward, and I will give credit here. If you go and you look at the federal pages that pertain to this information, they're actually using language there that makes sense, as opposed to what it was before. Like they'll say problematic substance use, for example, instead of just substance abuse. As in there, and they even acknowledge there that the vast majority of people who use some form of drug recreationally, they're going to go on to live their life and should be just fine. It's not, they're at least getting away from demonizing every single mind-altering substance.
Yeah.
And thank God, because it's not reality. Okay. I mean, people are going to use drugs. We know that this is going to happen. So we're adults. Let's figure out how to live with this situation in a way that makes it so that people can live their lives and not overdose. How about that?
Yeah.
So if we look at these 4 pillars here, we've got prevention, treatment, harm reduction, and enforcement. What are these in the new model? What do you think? Are we putting resources into each one adequately or evenly, or what does it look like to you?
Well, no, I don't think it's if by adequate you mean evenly, I don't think so. And if we look at what the actual functional costs of implementing each of these pillars is, no. The enforcement, if we include incarceration and like that sustained cost in this, I think the enforcement pillar is eating up a lot of money and a lot of resources. And I think the ones that I think harm reduction, it has gotten more attention and gotten more funding in the last number of years. But I look at the accessibility of treatment, and I look at the accessibility and the challenge, and we kind of encountered that challenge in our conversation about prevention. Mm-hmm. That's still a very hard one to place. that more time and attention is probably needed on prevention, and more money and resources are needed towards treatment to make it so that it's not an elite thing or a financially rooted thing.
Yeah.
One of the determinants of health by the World Health Organization is accessibility of healthcare. And if we can't access treatment because it costs 10 to 15 grand a pop, then we've got a problem.
Absolutely. We also have to define, like we talk about prevention, we talk about treatment. Well, what is the goal? I mean, they don't define, what do you mean by prevention? Prevention of what? Like what is the endpoint that we're trying to prevent here? We know we can't prevent drug use.
No.
That's going to continue to happen. So are we preventing, we want to prevent harmful substance use is what we're assuming. So those parameters need to be defined, and then those endpoints need to be recorded, and they need to be data driven so that we can see which way we're going. I mean, that would be a good starting point.
Agreed.
Same thing with treatment, right? I mean, I know that, I've tried to define recovery many, many times and asked a lot of people about it. So, I mean, I think if you look at treatment, well, you want to get that person back to a state where they're able to, they're able to manage their own life. I mean, that's a simple way of looking at it. And, whether they choose to continue to use substances in the future or not, that's their decision. But as long as they're able to continue they feel that their life is managed and that they're happy with that, then I think that person would be considered treated. But that needs to be defined on a federal level too.
Absolutely.
Again, so it can be tracked. But yeah, I think we both agree on the enforcement part of the structure there. It's the amount of money that's going in there, the amount of lives that are being ruined for, what was a stat I saw? This is a recent statistic, like from the last couple of years ago. The idea was with the new program that the enforcement dollars that were going in were going to be enforcement dollars to target high level distribution. That was the idea. And the last stats we got coming out is 73% of low level offenders are the ones going to jail. That's people mostly caught for possession or, like street trafficking.
Yeah.
So again, what you're saying and what you're doing are not the same. And that we can see it's not having an impact on distribution. So, I just, as far as setting your money on fire and walking away from the problem, you're doing a good job.
Yeah.
But if you want to use those dollars for something that actually helps Canadians to be healthier and to manage their lives better and, go on to reach a closer approximation of whatever he or she's potential is, then you're going to have to spend those dollars elsewhere.
Yeah. And imagine if that language was used, what you said, that really, really resonated with me, that if the goals of prevention and the goals of treatment were to support one's life and drug use potentially at being manageable. So for some people that would mean abstinence, but for some people that would mean sustained moderate controlled use. And if that was the goal, then suddenly that removes that sort of the criminal side of it, that removes the side of it that leads to premature death, that removes a host of the associated issues.
Yes.
Yeah.
It from my point of view, and obviously it's a limited one, I don't have access to, the people who are making these policies. I can only speak to what I know and what I've seen. But from my perspective, it looks to me like the project is not going very well and that some big adjustments have to be made if we're going to have any kind of a hope of turning this thing around.
Yeah. The question that you've talked about asking to people early on in treatment or in recovery is like, how is this working for you? How are you managing? If we as a country and as a province asked ourselves that same question, the answer would be very different than what we are seeing on a ground level.
Exactly.
Yeah.
Yeah. If BC was an entity that could express itself, how would it feel about the way things are going?
Yeah.
Say, I'm not doing very good.
Yeah.
I'm not doing very good at all.
Yeah.
Yeah. So, yeah, that's the state of affairs.
Yeah.
Yeah.
So we're not. I chuckle because that's not a particularly optimistic way to cap it off. But maybe it is. Maybe that the change is happening certainly slower than we hope for, and I know that a lot of other people in our province and in our country hope for. But I think we can only hope that people's sort of perspective on that continues to change, and that I hate to say that as people's lives are impacted through loss of loved ones or loss of people that they're connected to by this issue, that maybe that will change things. That would be the potential silver lining to come out of this crisis of premature deaths that are happening in our country. That if it changes people's mindset and says, we need to really, really reevaluate this whole story, that there could be a silver lining there.
Yeah, for sure. You could look at it like that. And it's important to remember that these types of changes are not impossible to implement. No. We could do this if we want to,
Yeah.
And we need to recognize that some changes have been made. I mean, although it doesn't look good from a treatment and a cause and effect point of view right now, at least in some respects, the language that's being used and the way, I mean, there's talk of the way even the stigma of being somebody who uses drugs is at least being acknowledged, and there's discussions going on about that. Whereas, that wasn't the case 20 years ago, right?
No, for sure.
So there's attitude shifts, and hopefully that eventually leads to a paradigm shift that changes the way we address this problem.
Yeah, absolutely.
All right, buddy. I think we'll leave it there.
Sounds great.
Okay. Yeah. So we will call that episode 10. If you want to catch us on YouTube, we're on there as well as Spotify. And check us out on there. And if you want to get a hold of us, it's US as in us at recoverymachine.org. So shoot us an email if you want to ask us any questions about the show, and we'll be happy to respond.
Yeah.
All right, Corey?
I think this is the maybe more than a lot of our other episodes. There's lots to discuss here. And so we welcome the discussion. We welcome the comments and the questions, or to challenge us on it, because the discussion is certainly better than silence and no discussion on this topic. So please feel free.
Absolutely. Yeah. I would, if any of our information is incorrect, or like Corey said, if there's something you disagree with, let us know.
Yeah.
All right. Thanks, Corey. And see you guys next time.
Thanks, Nathan. See you soon.